semboyan FKWM bahwa lulusan FKWM adalah dokter profesional yang dengan integritas moral serta soft skills yang prima, yang melayani dengan etika, disiplin, sopan santun, dan kasih. Tuhan memberkati kita semua.
derajat kesehatan jiwa. PDS KJI milik bersama, saling berbagi pada sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbakti, mengabdi pada ibu pertiwi.
Selamat pagi kepada semua. FK Widya Mandala, hari ulang tahun ke-10, tanggal 1 April 2021. Puji Tuhan dan selamat untuk kita semua. Saya ulangi apa yang saya katakan pada Judisium Sarjana Kedokteran Angkatan 1 dan 2. Selamat dan terima kasih atas kepercayaan Anda untuk memilih FKWM. Kepercayaan Anda memilih dan masuk FKWM sebagai angkatan pertama dan angkatan kedua. Sementara pada waktu itu masih banyak orang yang meragukan eksistensi FKWM. Kita telah membuktikan bahwa kita bisa untuk melalui keadaan permulaan yang sukar, antara lain dengan banyak peraturan tentang FK dan yang kadang suka berubah. Terima kasih atas dukungan Yayasan WM, Universitas Widya Mandala, dan Uskup Surabaya dalam perkembangan Fakultas Kedokteran Widya Mandala sampai sekarang. Dengan kerjasama yang baik serta disiplin dan doa, FKWM akan maju terus. Ya, mohon diingat semua yang FKWM bahwa lulusan FKWM adalah dokter profesional yang dengan integritas moral serta soft skills yang prima, yang melayani dengan etika, disiplin, sopan santun, dan kasih. Tuhan memberkati kita semua.
Lilin.
SKCI rumah kita, tempat mengabdi pada negara, bersatu berjuang untuk meningkatkan derajat kesehatan jiwa. SKCI milik bersama, saling berbagi pada sesama, berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDSKCI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDSKCI siap berbagi, mengabdi pada ibu pertiwi.
Selamat pagi kepada semua. FK Widya Mandala, hari ulang tahun ke-10, tanggal 1 April 2021. Puji Tuhan dan selamat untuk kita semua. Saya ulangi apa yang saya katakan pada Yudisium Sarjana Kedokteran Angkatan 1 dan 2. Selamat dan terima kasih atas kepercayaan Anda untuk memilih FKWM. Kepercayaan Anda memilih dan masuk FKWM sebagai angkatan pertama dan angkatan kedua. Sementara pada waktu itu masih banyak orang yang meragukan eksistensi FKWM. Kita telah membuktikan bahwa kita bisa untuk melalui keadaan permulaan yang sukar, antara lain dengan banyak peraturan tentang FK dan yang kadang suka berubah. Terima kasih atas dukungan Yayasan WM Universitas Widya Mandala dan Uskup Surabaya dalam perkembangan Fakultas Kedokteran Widya Mandala sampai sekarang. Dengan kerjasama yang baik serta disiplin dan doa, FKWM akan maju terus. Ya, mohon diingat, semboyan FKWM bahwa lulusan FKWM adalah dokter profesional yang dengan integritas moral serta soft skills yang prima, yang melayani dengan etika, disiplin, sopan santun, dan kasih. Tuhan memberkati kita semua.
sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbagi, mengabdi pada ibu pertiwi.
Selamat pagi kepada semua. FK Widya Mandala, hari ulang tahun ke-10, tanggal 1 April 2021. Puji Tuhan dan selamat untuk kita semua. Saya ulangi apa yang saya katakan pada Yudisium Sarjana Kedokteran Angkatan 1 dan 2. Selamat dan terima kasih atas kepercayaan Anda untuk memilih FKWM. Kepercayaan Anda memilih dan masuk FKWM sebagai angkatan pertama dan angkatan kedua. Sementara pada waktu itu masih banyak orang yang meragukan eksistensi FKWM. Kita telah membuktikan bahwa kita bisa untuk melalui keadaan permulaan yang sukar, antara lain dengan banyak peraturan tentang FK dan yang kadang suka berubah. Terima kasih atas dukungan Yayasan WM Universitas Widya Mandala dan Uskup Surabaya dalam perkembangan Fakultas Kedokteran Widya Mandala sampai sekarang. Dengan kerjasama yang baik serta disiplin dan doa, FKWM akan maju terus. Ya, mohon diingat semboyan FKWM bahwa lulusan FKWM adalah dokter profesional yang dengan integritas moral serta soft skills yang prima, yang melayani dengan etika, disiplin, sopan santun, dan kasih. Tuhan memberkati kita semua.
kesehatan jiwa. PDS KJI milik bersama, saling berbagi pada sesama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbagi, mengabdi pada ibu pertiwi.
Selamat pagi kepada semua. FK Widya Mandala, hari ulang tahun ke-10, tanggal 1 April 2021. Puji Tuhan dan selamat untuk kita semua. Saya ulangi apa yang saya katakan pada Yudisium Sarjana Kedokteran Angkatan 1 dan 2. Selamat dan terima kasih atas kepercayaan Anda untuk memilih FKWM. Kepercayaan Anda memilih dan masuk FKWM sebagai angkatan pertama dan angkatan kedua. Sementara pada waktu itu masih banyak orang yang meragukan eksistensi FKWM. Kita telah membuktikan bahwa kita bisa untuk melalui keadaan permulaan yang sukar, antara lain dengan banyak peraturan tentang FK dan yang kadang suka berubah. Terima kasih atas dukungan Yayasan WM Universitas Widya Mandala dan USUP Surabaya dalam perkembangan Fakultas Kedokteran Widya Mandala sampai sekarang. Dengan kerjasama yang baik serta disiplin dan doa, FKWM akan maju terus. Ya, mohon diingat semboyan FKWM bahwa lulusan FKWM adalah dokter profesional yang dengan integritas moral serta soft skills yang prima, yang melayani dengan etika, disiplin, sopan santun, dan kasih. Tuhan memberkati kita semua.
bersama. Berikan pendidikan pada masyarakat tentang kesehatan jiwa. Satukan hati untuk berbagi, kembangkan ilmu dan profesi. PDS KJI siap majukan ilmu kedokteran jiwa. Mantapkan hati, selalu peduli, setia untuk melayani. PDS KJI siap berbagi, mengabdi pada ibu pertiwi.
Selamat pagi kepada semua. FK Widya Mandala, hari ulang tahun ke-10, tanggal 1 April 2021. Puji Tuhan dan selamat untuk kita semua. Saya ulangi apa yang saya katakan pada Yudisium Sarjana Kedokteran Angkatan 1 dan 2. Selamat dan terima kasih atas kepercayaan Anda untuk memilih FKWM. Kepercayaan Anda memilih dan masuk FKWM sebagai angkatan pertama dan angkatan kedua.
Selamat pagi dan selamat datang kepada Profesor Paul, segenap tim dekanat, dosen Sivitas Akademika Unika Widya Mandala Surabaya, seluruh mahasiswa, mahasiswi FK UKWMS yang telah hadir pada acara Essential Learning pada pagi hari ini. Tak lupa menyapa good evening to Professor Anthony Setiawan, our speaker for today. Sebelumnya memperkenalkan saya Dr. Dave yang akan memandu jalannya acara pada pagi hari ini. Sebelumnya saya menghimbau kepada seluruh hadirin untuk dapat on camera selama acara ini berlangsung. Sebelum kita memulai acara pada pagi hari ini, kita akan memulai dengan berdoa. Saya mohon ketersediaan Dr. Merlin Joka untuk memimpin kita dalam doa.
Baik, terima kasih Dr. Dev. Izinkan saya untuk memimpin doa pada acara pagi hari ini secara Katolik. Bagi yang beragama lain, mohon dapat menyesuaikan. Dalam nama Bapa dan Putra dan Roh Kudus. Amin. Allah Bapa yang Maha Baik, terima kasih untuk hari yang baru ini. Pada kesempatan ini kami bersyukur karena oleh kemurahan-Mu, FK UKWMS boleh merayakan Dies Natalis ke-11 di tahun ini. Kiranya wujud kebahagiaan kami melalui rangkaian acara Dies Natalis tahun ini boleh menjadi berkat dan manfaat bagi banyak orang. Kami mohon bimbingan-Mu Bapa selama berlangsungnya acara pagi hari ini. Arahkanlah pikiran, perkataan, dan perbuatan kami agar dalam Dikau kami memulai dan menyelesaikannya. Doa yang kurang sempurna ini kami serahkan kepadamu demi Kristus Tuhan kami. Amin. Dalam nama Bapa dan Putra dan Roh Kudus. Terima kasih, Dr. Dev.
Terima kasih, Dr. Merlin. Selanjutnya, mari kita menyanyikan lagu Indonesia Raya, diikuti oleh Mars Fakultas Kedokteran Unika Widya Mandala Surabaya. Saya dimohon setiap peserta untuk mengambil posisi sempurna.
Indonesia, tanah airku, tanah tumpah darahku. Di sanalah aku berdiri,
Selanjutnya, mari kita dengarkan kata sambutan. Selanjutnya, mari kita dengarkan kata sambutan terbuka dari Dekan FK UKWMS. Kepada Profesor Paul Tahalele, waktu kami persilahkan.
Selamat pagi dan good evening, Profesor Antoni Setiawan. Pada hari ini kita mengucapkan puji syukur kehadirat Tuhan Maha Kuasa karena dalam rangka ulang tahunnya yang ke-11, Fakultas Kedokteran kami yang masih muda ini telah memberikan beberapa kemajuan di dalam proses belajar mengajar maupun hasil-hasil karya daripada sivitas akademika. Juga tidak lupa selamat pagi untuk Dr. Puji Januarto sebagai Direktur Rumah Sakit Pendidikan Utama dari Fakultas Kedokteran Unika Widya Mandala, Surabaya. Untuk semuanya, para wakil dekan, juga para hadirin sekalian, para mahasiswa yang saya cintai, selamat pagi dan salam sejahtera. Semoga kita dalam keadaan sehat walafiat, dan pada masa ini adalah masa peralihan, semoga pandemi ini segera berakhir. Pada kesempatan ini juga saya ingin berterima kasih pada Prof. Antoni. Ya, kita sudah lama sekali, 50 tahun yang lalu ya. Prof. Antoni belajar meninggalkan Surabaya ke Amerika Serikat. Dan sekarang kita ketemu di muka laptop ini. Dalam keadaan sehat, Prof. Antoni. Sekali lagi terima kasih, Prof. Nanti 2 minggu lagi beliau juga akan memberikan lecture tentang hal yang sama, yaitu dalam bidang radiologi, dan yang dibahas adalah aspek pemeriksaan menggunakan CT scan untuk kelainan-kelainan abdomen. Bagi para mahasiswa, ini adalah kesempatan yang paling baik karena dekanat berusaha bersama-sama juga dengan Rumah Sakit Pendidikan Utama maupun jejaring memberikan wawasan, wacana agar kita juga mempunyai wawasan internasional ya. Tentunya ini berkat juga kerjasama kami bersama dengan Persatuan Jerman Indonesia, jadi alumni-alumninya, di mana saya juga duduk di sana. Kemudian dengan diaspora Indonesia dan juga dengan International College of Surgeons, di mana saya juga sebagai council members dari International College of Surgeons yang berpusat di Chicago. Ini adalah suatu kerjasama yang baik karena untuk meningkatkan pendidikan kedokteran di Indonesia, kita perlu juga mendengar apa yang terjadi kemajuan-kemajuan di dunia internasional. Oleh karena itu, kesempatan ini mohon dimanfaatkan dengan baik. Sekali lagi, once again, thank you very much, Profesor Antoni. And I'm sorry because we have the different links between United States and Indonesia, but it's okay. Once again, thank you very much.
Terima kasih Profesor Paul atas sambutannya. Kata sambutan selanjutnya dari Kepala Rumah Sakit PHC Surabaya. Kepada Dr. Puji Januartono, waktu kami persilahkan.
Terima kasih, Dr. Dev. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Pertama-tama, marilah kita panjatkan puji syukur kehadirat Allah SWT bahwa di pagi hari ini kita semua masih diberi nikmat sehat, nikmat waktu, sehingga bisa mengikuti acara yang luar biasa ini. Prof. Paul, terima kasih Prof. Senior saya, guru saya, terima kasih banyak. Kemudian jangan lupa terima kasih Prof. Antoni dari Dallas, Amerika, luar biasa, mau membimbing kami yang ada di Indonesia. Kemudian Dr. Epri sebagai moderator, kemudian teman-teman sejawat yang lain yang ada di FK Widya Mandala, dan juga para mahasiswa. Menarik sekali acara kali ini dalam rangka perayaan ulang tahun ke-11 FK Widya Mandala. Dalam rangka itu maka luar biasa dari visi misinya Prof. Paul untuk jangan sampai kita ketinggalan. Jangan sampai kita ketinggalan dengan perkembangan yang ada di luar negeri. Jadi kita selalu mengikuti lah ini mengetengahkan pembicara-pembicara yang dari luar negeri. Luar biasa Prof, selamat Prof. Jadi ini langkah yang luar biasa. Kami dari Rumah Sakit Pendidikan Utama akan support full Prof. Semua kegiatan yang ada di FKWM untuk sama-sama belajar, sama-sama maju sehingga Indonesia khususnya Surabaya tidak ketinggalan atau malah sejajar dengan pelayanan-pelayanan yang ada di luar. Dan juga untuk adik-adik mahasiswa ini hal yang kesempatan yang luar biasa. Jadi kita bisa melihat bagaimana perkembangan di luar sehingga kita kalau merasa ketinggalan, kita harus memacu diri untuk maju. Kalau merasa sama, kita tetap harus lebih maju lagi. Nah, itu suatu hal yang luar biasa. Jadi sekali lagi selamat FKWM, luar biasa Prof, luar biasa majunya. Nah, untuk itu mudah-mudahan di pertemuan kali ini Tuhan Yang Maha Esa mempermudah dan meringankan usaha kita sehingga apa yang menjadi tujuan kita bisa tercapai. Sekali lagi terima kasih, mohon maaf bila ada yang kurang. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih. Terima kasih Dr. Puji.
Terima kasih kepada Dr. Puji untuk kata sambutannya. Acara selanjutnya akan dipimpin oleh Dr. Efrianto Darmadi, spesialis radiologi. Sebelumnya izinkan saya untuk membacakan kurikulum vitae dari beliau. Tim IT, minta tolong. Dr. Efrianto lulus dari Fakultas Kedokteran Universitas Gajah Mada dan menyelesaikan pendidikan dokter spesialis radiologi dari FK Universitas Erlangga. Saat ini beliau berdinas di Rumah Sakit PHC Surabaya sebagai seorang radiologis. Beliau merupakan anggota ID dan juga anggota dari PDS RI. Kepada Dr. Efri, waktu dan tempat kami persilakan.
Terima kasih Dr. Dev atas kesempatan ini. Selamat pagi semua. Yang terhormat Prof. Dr. Paul Talele, spesialis BTKV Konsultan, sebagai Dekan Fakultas Kedokteran Katolik Widya Mandala Surabaya. Kemudian Dr. Puji Januartono Mars, sebagai Direktur Rumah Sakit PHC Surabaya. Dalam hal ini sebagai Rumah Sakit Pendidikan WKWM. Kemudian Prof. Dr. Antoni Setiawan PhD sebagai pembicara kita pagi hari ini dari Dallas, Texas, USA. Dan juga selamat pagi kepada seluruh partisipan Selamat datang dalam acara The First Essential Learning Series. Ya. Saya Dr. Prianto sebagai moderator yang akan memandu seminar pagi hari ini. Ya. Saya sangat senang sekali bidang radiologi mendapat update pengetahuan ilmu tentang dalam hal ini tentang USG. Partisipan dalam kesempatan ini bisa mengikuti acara garis besar dalam tentang the role of ultrasound in abdominal examination. Saat ini pemeriksaan USG atau termasuk modalitas USG berkembang sangat pesat ya, dalam mendukung untuk mendiagnosis, membantu imaging penyakit-penyakit dalam hal ini di salah satunya penyakit-penyakit di organ abdominal. Banyak variasi pemeriksaan USG ya, mulai dari Doppler, terus vibroscan dan sebagainya. Kita bersyukur dalam kesempatan ini dapat kesempatan dari pakar aslinya dari Amerika ya. Jadi dalam kesempatan ini akan saya tampilkan kurikulum vitae dari Prof. Dr. Antoni Setiawan, PhD. Mungkin bisa saya tampilkan. Prof. Antoni jadi sempat mengambil pendidikan dokter di UNER, ya, kemudian melanjutkan di Departemen Anatomi Trisakti, kemudian melanjutkan di bidang radiologi di Universitas Surabaya dan di University of Texas Medical School, kemudian mendapat profesor mulai 2010 hingga sekarang di University of Texas Medical School. Kemudian beliau sangat aktif sampai saat ini di bidang radiologi, ya, di St. Paul University Hospital, di University, kemudian di Clements University Hospital. Banyak aktivitas beliau di bidang radiologi dalam hal ini termasuk sebagai Director of Ultrasound, serta Moderator dan Director of Abdominal Imaging bagi hospital. Mungkin untuk menyingkat waktu, kami silakan Prof. Antoni. Jadi mungkin sebelum mulai, jadi nanti acara setelah sesi pemaparan materi, ada sesi tanya jawab. Peserta bisa raise hand untuk menanya atau mungkin bisa nulis di chat box ya. Jadi nanti akan diisi tanya jawab di proses setelah akhir sesi presentasi dari Prof. Dr. Antoni. Saya kira waktu saya serahkan sepenuhnya ke Prof. Antoni untuk menyajikan materinya, ya. Jadi kami undang. Saya kira selamat pagi, Prof. Atau selamat malam, Prof. Antoni. Maaf, masih mute, Prof. Masih mute, Prof. Antoni. Ya.
Oke, sekarang bisa dengar.
Baik, Prof. Selamat.
Oke, good.
Jadi saya persilakan waktu. Jadi untuk menyajikan materinya mungkin waktu kurang lebih 40 menit. Kemudian nanti dilanjut sesi tanya jawab, Prof. Silakan, Prof.
Yes. Oke, so selamat pagi untuk para rekan-rekan sejawat di Surabaya dan juga untuk para mahasiswi kedokteran dari Widya Mandala. Saya sangat senang dan berterima kasih bisa ikut merayakan ulang tahun dari Widya Mandala yang ke-11. Terima kasih untuk Dr. Tomati untuk nice the introduction. Saya juga mau terima kasih untuk Profesor Tahalele yang telah memberi kesempatan pada saya untuk share saya punya pengalaman sama bekerja di United States. Ini slide pertama ini adalah sebagai background ini downtown atau pusat kota Dallas di waktu malam. Dan kira-kira 7 km utara dari itulah tempat saya bekerja. Jadi ini seluruh kompleks dari University of Texas. Tidak termasuk di sini ada rumah sakit neurologi dan neurosurgery dan juga rumah sakit spesial untuk anak-anak. Saya setiap hari bekerja terutama di Parkland Hospital, itu adalah semacam RSUP gitu buat kota Dallas, dan juga kadang-kadang bekerja di rumah sakit private dari university. Kedua-duanya ini rumah sakit yang belum lama, masih baru. Sebelum itu 40 tahun yang lalu saya mulai bekerja di rumah sakit yang lama. Jadi ini Old Parkland Memorial Hospital. Ini 60 tahun yang lalu rumah sakit ini sering di dalam warta berita karena tempat inilah yang di Presiden John Kennedy waktu ditembak di downtown Dallas dibawa ke sini. Sayang dia meninggal juga di rumah sakit ini. Dan rumah sakit ini sebelumnya pindahan dari rumah sakit pertama sekali di daerah sini, kira-kira 7 km dari sana. Rumah sakit ini RSUP yang pertama di Dallas tahun 1894. Ini rumah sakit dari kayu dan bisa dilihat ini ambulans pertama dari kota Dallas masih ditarik sama kuda. Okay, so let's get down to business. Ini dalam presentasi ini saya di kira 4-5 bulan yang lalu, Profesor Tarlili menghubungi saya untuk ada interest memberi lecture radiologi pada mahasiswa-mahasiswa di Widya Mandala dengan topik ultrasound, kegunaan ultrasound di abdomen. Dan waktu pertama saya agak ragu-ragu sebab ada beberapa masalah. Jadi ultrasound di abdomen itu topiknya luas sekali. Jadi akhirnya saya decide untuk narrow down untuk role ini. Jadi Role of Ultrasound and Acute Abdominal Pain. Jadi ini lecture ini saya akan berguna sekali untuk keadaan darurat untuk pasien yang masuk dengan sakit perut di UGD. Dan masalah lain juga ini saya menyadari bahwa audiensnya ini a very mixed audience. Jadi dari mahasiswa kedokteran sampai orang-orang yang ahli di ultrasound seperti Dr. Darmadi, radiologist. Jadi akhirnya saya pikir saya berhasil membuat lecture yang balance. Tapi kalau ada hal-hal yang sangat basic untuk para hadirin, tentu saya mau minta maaf. Dan masalah ketiga itu adalah masalah bahasa. Saya sudah hampir 50 tahun tidak menggunakan bahasa resmi Indonesia, jadi banyak istilah-istilah Indonesia yang saya tidak paham, terutama di bidang medis. Jadi karena itu saya mohon maaf, ini saya decide untuk present lecture ini dalam bahasa Inggris. Itu untuk saya itu lebih lancar, jadi lebih comfortable. So here we go. Okay. Pertama, untuk bisa mengikuti lecture ini, saya minta selalu tentang orientation. Just orientation. So the images are usually, most of the time, it is either a transverse or axial or sagittal image. Okay. And as you see here on transverse image, the patient is lying supine. We're looking from the feet up. So the left side is here and the right side is there. The sound beam coming in a cone shape, and only this part is going to be imaged. So as a result, we're going to see an image like this. So this will be anterior, posterior, because the patient is supine. This will be the left side, that will be the right side. On a sagittal image, the head is always displayed on the left. Okay, and again, if we look at the send the sound wave in a cone shape in this area, we're going to end up with an image like this. So again, this would be anterior, posterior, cranial, caudal. Okay, so that's the orientation. A little bit about terminology. During this lecture, I'm going to oftenly refer to something with the word echo. So let's talk about a little bit about the echo concept and ultrasound. Ultrasound is basically created by sending a sound wave into the patient, and it's going to bounce off to a certain structure. In this case, it's a gallstone and a gallbladder. And the sound wave is going to return back and back to the origin, to the machine, and that's where it was digested and produced an image. So basically anything that you see on this image, whether it's a dot or a line, is a result of an echo. Okay. So during the talk, I'm going to refer oftenly describing something with the word echo. So for instance, this is a cyst in the liver. And when I describe this cyst, I'm going to say this cyst is anechoic, meaning there is no echo, I mean there's no dot in it. Okay. Here we have a mass with solid mass with all kind of different density. If I'm going to describe this nodule, I'm going to say that this nodule is hyperechoic in comparison to the surrounding. If I'm going to describe this area, I'm going to say this area is hypoechoic compared to the rest of the liver or to this nodule. And the word isoechoic is that used if they have the same echogenicity. What you see on the images are not all that is in the patient because there's some limitation of ultrasound. The biggest enemy of ultrasound is air or gas. So we cannot scan, like for instance, the contents of the chest. We cannot scan to the lung. Even in the abdomen, when the ultrasound wave hit the bowel gas, then it's going to be blocked. It's going to just bounce off of the air or the bowel. Bone is another problem. So if you put a probe on the patient's head, for instance, you're not going to be able to see the brain. And finally, which I think is the biggest limitation of ultrasound, is operator dependency. So it depends where the operator places the transducer and also how the transducer is angled is going to produce a certain image. So that's actually the biggest limitation of ultrasound. Okay, so with that aside, let's talk about patient who come with a good abdominal pain. So this patient generally show up in the emergency room. I think in Asia we call it UGD. And the first thing you always ask the patient, where does it hurt? Sakitnya di mana? Right. And so in this talk, I'm going to divide it in areas where the patient say complain with pain in the right upper quadrant, epigastric pain, flank pain, abdominal plus back pain, and the lower abdominal pain. Okay, so I'm going to start with the pain in the right upper quadrant. So we'll look at these organs that is in the right upper quadrant, the gallbladder, the bile ducts, and the liver. Any of these could be the source of this patient's symptom. Start with the gallbladder. Obviously, the thing is about acute cholecystitis. Does the patient have acute cholecystitis? So with that, I'm going to start with talking a little bit about how the pathophysiology of acute cholecystitis. So we start with a small stone that obstructs the cystic duct. And the gallbladder function is actually to increase the bulk of bile. So the gallbladder secretes mucus, and because the cystic duct obstructed, the gallbladder becomes over-distended. At this point, when we look at ultrasound, we see a round, what I call a round dense gallbladder. So the shape of the gallbladder is round because of the pressure. Clinically, the patient will complain of right upper quadrant pain. And if you look at it, it's right where the gallbladder is. However, that's all the finding that you can see clinically. If the obstruction continues, the gallbladder becomes ischemic. And now we got bacterial invasion because bile is not sterile. And now we get acute cholecystitis. So there's a lag time between overdistension with the patient having right upper quadrant pain to about maybe 6 to 12 hours before we get acute cholecystitis. And at this point, the gallbladder would be, see, I think this is covered here. The gallbladder would be edematous and also be tender. So there's a difference between right upper quadrant pain over the gallbladder and tenderness. So in the patient with tenderness, when we press over the gallbladder and let go, then we have peritoneal pain. Because if the gallbladder is infected, the surrounding also become inflamed and will irritate the peritoneum, i.e. you have localized peritonitis. Clinically, also become positive. Patient are febrile, have an elevated white count, and so on. There is an entity called acalculous cholecystitis. So cholecystitis occur in very sick patients, and these patients are often hypertensive, so gallbladder ischemia as a result, and also a lot of time the septic both and bacterial invasion also can result in acute cholecystitis. So what is the ultrasound diagnostic criteria for acute cholecystitis? We already talked about this round dense gallbladder. We have this gallbladder thickening or edema, all visible on ultrasound. And we have focal tenderness. And this on the ultrasound language is known as the ultrasound Murphy sign. The presence of gallstones. Notice that on purposely, I put this in small letters. So, some kind of saying that this is not that essential. I'm going to explain in a minute why that is. So this is an example of a gallbladder that's collapsed. This gallbladder is under no pressure. There's no overdistension. And remember that the acute cholecystitis pathophysiology started with overdistension. So this is a patient where you can rule out acute cholecystitis. This, on the other hand, is what we call a round dense gallbladder. The gallbladder is under pressure and pushes the liver around to obtaining this kind of shape. So this is a base example for patient with acute cholecystitis. We here have a round dense gallbladder. Patient have a lot of gallstones. This is an artifact that we see distal or deep to the gallstone. All the sound is bounces by the stone, sort of blocked, so there's no more sound wave seeing beyond that. And we get an artifact called acoustical shadowing. So there's actually a main criteria for detection of gallstone on ultrasound. So we have the overdistended gallbladder. We have an ill-defined thick wall, just here, and we have the gallstones. Now, the word ill-defined is important because there's a lot of other entities that also give you gallbladder edema, but this time the margins are very well defined, sharply defined. And this patient have a right heart failure. So in right heart failure, where everything become edematous, not only just the skin, the peritoneum, bowel, gallbladder included. Other condition and give you anasarca like low hypoalbuminemia can present the same way. There's some other conditions like acute viral hepatitis, patient with CMV, cholangitis, like an AIDS patient, and patient with acute pancreatitis can also get this kind of edema. But they look different than acute cholecystitis edema, which is kind of indistinct. Now, stones, there's another example of a large stones in the gallbladder. Now, the cystic duct is a very small structure. Okay? So the anatomy of cystic duct say that the cystic duct in general is about 2 to 3 millimeter. Okay? And remember that the acute cholecystitis started with an obstruction of the cystic duct. So in other words, these large stones would never be able to fit in that cystic duct. It must be another tiny stone that sort of is this size, maybe 2, 3 millimeter or less, that happen to obstruct the cystic duct. So in other words, that the gallstone that's visible in it, and these stones are being so small, and in general, because the cystic duct is so small, we don't see them on ultrasound. So the gallstone, the stone that is visible in the lumen, is not the cause of acute cholecystitis. And the obstructing stone in general is not visible in ultrasound. Okay? And that's why the reason I put the gallstone as a sign of acute cholecystitis as sort of at the bottom in small letters, because this is not actually the cause of the acute cholecystitis. This next case kind of highlight that concept. There's a patient that came in on the 21st of September with right upper quadrant pain, was not tender. So the initial report by the resident, I think resident in Indonesia is like the assistant. So the radiology resident on call that night say there was no sonographic Murphy sign. The patient was afebrile. White count was a little bit elevated, not by much. Okay, so the final diagnosis on that night from the ultrasound was abnormal gallbladder, and the patient got some pain medication and went home. Came back the next day, still febrile, and now the white count is 25K. And then they did a CT because they will already have the ultrasound, so I mean, to see what the CT looked like, and this is what the CT was. So a lot of inflammation around the gallbladder. This is the definite or the classical sign of acute cholecystitis on CT. The patient went to surgery, and the PET said gangrenous gallbladder. So this patient have a tiny stone that obstruct the cystic duct here that we never saw, that continue to obstruct continuing acute cholecystitis, give you the gangrenous gallbladder. What was not observed that night was the appearance of the gallbladder. Okay, so I would call this a round dense gallbladder, and at least raise the possibility that the cystic duct might be obstructed. Okay, so that's about gallbladder. Now, next time we're going to move to the bile ducts. And obviously, we're going to talk about biliary obstruction. So that's the only condition of that causes abdominal pain. And for that, I'm going to start with talking a little bit about the anatomy of the biliary tract. Okay. So the biliary tract has a common duct. Notice I don't call this common hepatic or common bile duct because we do not see the cystic duct in general. So anywhere here, we just call a common duct. Next part up here is the main intrahepatic ducts. These are the bile ducts that follow the right and the left portal vein, and also the segmental branches. So these are still considered the main intrahepatic ducts. And then finally, we have the peripheral or small bile ducts. These are the small ducts that are in the periphery or the subsegmental branches. Now, we use this anatomy to classify biliary obstruction. So basically, three types of obstruction: acute, subacute, and chronic. Acute, by definition, is obstruction that occurs 6 to 12 hours after the event. And almost all surgical biliary obstruction are extrahepatic. So 6 to 12 hours after obstruction, we get acute obstruction. And what we see on imaging, including ultrasound, is a dilated common duct only, nothing else. Subacute obstruction is if the obstruction continues 24 to 72 hours, then aside from the common duct dilatation, we can also see the main intrahepatic duct dilatation. Notice that on both situations, acute and subacute, the duct will be smooth. Chronic obstruction, if it continues to more than a week, then aside from the common duct, the main intrahepatic duct, now we have the peripheral duct dilatation, and all these ducts become tortuous. Anything that is obstructed in a chronic base will be tortuous. Just look at varices, they are tortuous. Okay. So now we're not going to talk about the chronic obstruction because that's does not cause any pain. But by able to classify the obstruction, we can sort of getting close to the cause or the etiology of the obstruction. Acute obstruction is almost always due to an ampullary stone in the ampulla of Vater. Okay. So unless you have a patient with a rapidly expanding duodenal hematoma causing the obstruction of the bile duct, for all practical purposes, when we have a patient with an acute biliary obstruction, the cause is a stone in the ampulla. Subacute obstruction, the cause is a bit longer. Sometimes this little stone pass and the ampulla is still edematous and spastic, so the obstruction continues. And also other causes of edema of the ampulla, we've seen with patients with acute pancreatitis or acute duodenitis. Chronic obstruction, there's not that many choices, so the obstructing mass or a biliary stricture. Okay. So we're not going to talk about chronic obstruction because this is not causing any abdominal pain. So the other way to classify obstruction is by looking at where the patient obstructed, what's the level of obstruction. If the obstruction is here, we call it an ampullary obstruction. So in this case, the whole biliary tract will be dilated. Obstruction at this level is called pancreatic obstruction. And then we sort of divide this in a mid-portal, high portal, and quote-unquote intrahepatic. Because an imaging can look like this part is in the liver, actually is technically still outside in the porta hepatis. Ampullary obstruction, stone. Pancreatic obstruction is almost always a carcinoma. Mid-portal, well, there are not that many structures here. We have the stomach duodenum. Theoretically, you can have a big gastric carcinoma that spread outside the stomach and start a compression in the common duct. But remember, there's a lot of lymph nodes in this area. So if there's any metastasis, this lymph node can press on the common duct. So lymphadenopathy, most common cause there. high portal, we still have a lot of lymph nodes in this area, but also remember now we're getting close to the region of the gallbladder. Okay, so there's any gallbladder carcinoma, for instance, it can invade this common duct, causing a high portal obstruction. There's a rare situation where you can have a stone in the gallbladder that perforate and press on the common duct, called the Mirici syndrome. This is kind of rare though. And then the intrahepatic obstruction is due to a cholangiocarcinoma that's sitting right there. So cholangiocarcinoma could occur anywhere along the tract, but this cholangiocarcinoma, this area has a special name called Klatskin tumor. So by combining the two classifications based whether it's acute, subacute, and chronic, and by trying to define what the level of the obstruction, in general, we can get pretty close to the etiology of the obstruction, or at least come with one or two differential diagnoses, and then we can suggest a further appropriate workup. So how do we miss the common duct? So this is the region of the portal hepatis. We have these three main structures going into the liver. The main portal vein, you get the hepatic artery that kind of branches before you get to the portal hepatis, and then you have the common duct. A cross section in this area gives you this kind of anatomy, where the common duct is on top and a little bit to the right of the portal vein. So if one scan in this plane, we're going to see the two structures, the common duct on top of the portal vein. And this is kind of the image that is like that. So here we have the portal vein. Here we have the common duct on top and to the right of it. Normal diameter of the common duct is 6 millimeter. Inner to inner measurement, regardless of patient's age. Okay. And then when you get old, a lot of the things we lose when we get older, and one of them is this elastic tissue. This is why we got wrinkles and everything. And it happened also with the common duct. The loss of elasticity may cause the common duct to start to dilate. Generally, not always, is about 1 millimeter per decade. So starting at age 60. Okay. So when the duct is over 1 cm, then we say this is dilated. Because if you count the math, then a 1 cm duct would be okay for a patient that's 100 years old. So everything above 1 cm is definitely abnormal. So this is an example of a dilated common duct. So the main intrahepatic ducts, like I mentioned, is these ducts that are following the portal vein. So there's an example of the right intrahepatic duct. So here we have the right portal vein. There's a structure that runs with it. So this is the right hepatic duct. We do not have measurements, normal measurements for these ducts. But what we do is we compare it with the adjacent portal vein. So the duct should not be more than half, or actually the original article said 40%, but I use half because I can just eyeball it very easily. So this is obviously normal, and this is an example of a dilated left intrahepatic duct. Here we have the left portal vein, the right portal vein. There's another tubular structure that's obviously more than half the size of the adjacent portal vein. And this is the original article that was written somewhere in the mid-80s. It's called the parallel channel sign. Okay. There's a patient with a common duct that is dilated, and when we follow this common duct, we eventually see the cause of the obstruction, which is a stone. Okay, and this is way down already in the head of the pancreas. This is quite distal. This is actually not that common because oftenly we outside of the liver. We got a lot of bowel gas in this area. So oftenly the distal common duct near in the ampulla is usually blocked by bowel gas. But this is sort of in a nice case showing you the stone that blocking this common duct. This is the appearance of stone, the same thing like we see on the gallbladder. We got a hyperechoic echo here, focused with acoustical shadow. Now, when we have a dilated common duct, we always look at the whole abdomen. And in this particular patient, we also saw a dilated pancreatic duct. So this is a transverse image. You see the aorta and the IVC here and a color Doppler. This is the splenic vein. Here we have the body of the pancreas kind of cross over the SMA, which is right here. And that's the pancreatic duct. Normal pancreatic duct is about 2 to 3 millimeters. So this is obviously dilated. Okay. So the concern here is remember that the pancreatic duct and the common duct in most patients have the same empty in the same place at the ampulla. So if the common duct is obstructed, the pancreatic duct can be obstructed as well. And a pancreatic duct obstruction will lead to pancreatitis. So we have patient with biliary pancreatitis. We move to the liver as the cause of the right upper quadrant pain. Here we have a patient, the young patient, 23-year-old. It's a Latin American male. I think he's from Honduras. Patient come with right upper quadrant pain, tenderness, fever, white count. So it's always obviously some infectious process. The ultrasound, we found a big mass here. It's a kind of complex mass, have some cystic component, fluid component. This is not an artifact that indicates that this is a fluid, which is called the increased tooth transmission or enhancement. But there's also a lot of solid components. So it could be any mass, it could be a necrotic tumor, it could be a hamartoma, but this patient is septic. And also then combining the fact that he's from Honduras, a lot of South America is endemic of amoebiasis, so the diagnosis is an amoebic abscess. Okay, so of course that still needs to be confirmed. To be sent in the lab for antibody and antigen for amoeba. Okay, so we move to the next area, pain in the epigastrium. Okay, so here, in the midline beside the stomach, patient have acute gastritis, but you're not going to see anything on ultrasound. So the other cause of the acute epigastric pain is acute pancreatitis. So here's the patient, as an alcoholic abuser, come with epigastric pain, nausea, vomiting, elevated serum amylase and lipase. So this obviously patient with acute pancreatitis. Imaging show a enlarged edematous pancreas, have a dilated common duct that you see here. And then we further look in the liver. We on the right upper corner, we've also found a dilated common duct. And in the liver, we have that dilated intrahepatic duct. So remember, if you have a dilated common duct plus the main intrahepatic duct, the obstruction is subacute. So that kind of corresponds to the pancreatitis as a cause of the subacute obstruction. Notice that this common duct is kind of running horizontally in a transverse plane. Okay, and this is actually this part of the common duct. This is kind of covered up a little bit. Let me see if I can get rid of that. Okay, so this part here is the part that hooks into the duodenum. That's why it kind of runs in this direction. So the conclusion is that the obstruction is right there at the ampulla. So in order for this thing also to be dilated. So this is a subacute ampullary obstruction, an example of that, and it's due to the patient with acute pancreatitis. So what is the role of ultrasound in acute pancreatitis? Actually, not much, because acute pancreatitis is a clinical diagnosis. If a patient with symptoms and have an elevated amylase lipase, then you call it acute pancreatitis. And also, the pancreas is awfully normal in ultrasound. Pancreas is an organ without a capsule, so all this edema, all this inflammation will actually usually spread in the surrounding of the liver, and the pancreas decompress and never become enlarged or even edematous. The question is to look at the bile ducts. If the bile duct is also dilated, then the question is the common duct dilated because the ampulla is edema or edematous or spastic? Or is the biliary pancreatitis, is the stone that blocked not only the common duct, but also the pancreatic duct, causing a biliary pancreatitis? Okay. So if the patient does not improve and the common duct obstruction continues, the patient starts to have some lab numbers indicating biliary obstruction, then the next step to do is an endoscopic ultrasound where you can find the stone and extract that. Next, we're going to move a patient with flank pain. Okay, so typically, flank pain or pain in the costovertebral angle points to the kidney. So we're looking for stone or potentially a renal abscess. So this is the ultrasound sagittal image of a normal kidney. So here we have the renal parenchyma. This is the fat in the renal sinus, the center of the kidney. The renal pelvis and calyces are not seen because they're normally collapsed. Okay, so that's a normal kidney. If the kidney becomes hydronephrotic, then the fluid will expand the calyces. So here you have the calyces, the major calyces, and the renal pelvis. Okay, so this is the ultrasound diagnosis of hydronephrosis. So obviously, if the stone is obstructing downstream, then the proximally or upstream, the system will dilate and we end up with hydronephrosis. Now, finding the stone, if the stone is large enough, then we see, as like any other calcification of stone, like the gallstone, we see a hyperechoic echogenic focus with a acoustic shadow. Okay. And we can also see the stone when it arrive at the uretrophysical junction. Here we have the bladder on transverse and then sagittal. That's the distal ureter with the stone in it. Here you can follow the dilated ureter and the stone at the end. Okay. There's another example of a stone in a hydronephrotic kidney. And when we turn the color Doppler on, okay, we get an strange artifact that we call twinkle artifact. So this is not due to motion because there's no flow in the stones, but it's just an artifact that occurs when you turn the color Doppler on. Okay? And we use that to detect smaller stone. So this runs a patient that maybe we can call a stone there, I'm not really sure, but when we call a color Doppler on, we got all these twinkle artifacts, and we can see, well, this patient has small stones. Okay. However, even with these twinkle artifacts, there's a limit how small a stone ultrasound can see. So generally, if the stone getting around 3 millimeter, we start having trouble seeing the stones, especially in large patients. So stones like this on a CT, we call this a punctate stone. It's very hard to measure, maybe 2 millimeter or less. These stones would definitely not be able to see an ultrasound. And also stone that are in the ureter, because once the stone is down here, it's going to cover by overlying bile gas, and ultrasound doesn't penetrate gas, so we're not going to be able to see this stone. And you can see why that is. That's the same stone here. I notice all these bile loops in front of it. Okay. So stone that are small and stone in the ureter are not visible at ultrasound. So in general, for patients with flank pain, we prefer CT. So unless sometimes in patients that are pregnant, we start with an ultrasound and we see we can be lucky, find a stone in the kidney, and if the stone at the uretrophysical junction, if there is hydronephrosis, it'd be tough because a lot of patients with that are pregnant also have a little bit of a hydronephrosis. Okay, so another situation, you have a patient with flank pain, but this time there's tenderness and the patient is septic. So now we start thinking about an infectious process. Pyelonephritis is something that is generally not diagnosed with ultrasound because we don't find any finding in pyelonephritis. This is a renal abscess. Okay, so here we have a large mass, but this is increased to transmission, indicating that whatever this look like, this is actually fluid. And then plus on top of that, we have the clinical supporting sign indicating that this is an abscess. So now next one, we're going to go to patient that come with abdominal pain in combination with back pain. So there's an unusual combination, and you start thinking of patient that having an aortic, abdominal aortic aneurysm. So this is a normal aorta. It's a nice tubular structure, and an aneurysm easy to detect because we got a focal dilatation like that. Okay. Another cause that of acute abdominal pain with back pain in combination caused by the aorta is a dissection. So we can see this dissecting flap. Now, the problem with this is that using ultrasound as the abdominal aorta is often not completely seen, because once you're outside the liver, we get in the territory where there's a lot of bile gas. And in this patient, for instance, is very skinny, and you notice there's no bile gas in front of it. But if you have a lot of bile loops in this area, this part would not be visible. Okay? Someone will try with gentle compression, try to push the bile gas away. But the fact, though, is that a lot of patients, we're having trouble seeing the entirety of the abdominal aorta, unless the aneurysm is big enough. Okay. So, and the other thing is that ultrasound actually does not explain that the abdominal aorta is the cause of the pain. Okay, the patient with an aneurysm generally are not having pain, and they start having pain if there's an inflammation around the aorta. And the theory of that is there's a micro leak of this of the aneurysm, and this causing inflammation around the aorta, the aortitis, and that's just causing the pain. And that's something that we can see with CT. Okay, so once the patient have this kind of pain and showing an aneurysm, generally we send them to CT. CT can also look at other things like a deep ulcer that has a risk for rupturing. So generally we use ultrasound more for follow-up. Okay, so once we found an aneurysm, we follow this patient up 6 months, every 6 months, annually to make sure that this aneurysm is not progressing, getting large. And generally, if the aneurysm reaches 5 cm, then it's considered high risk for rupture. So the patient will be scheduled for surgery or some kind of stenting. Finally, we have pain in the lower abdomen. Okay, so lower abdomen, acute appendicitis, and also remember that acute OB-GYN conditions. Okay. This is an example of acute tip appendicitis. So it's a kind of rare appendicitis that only affects the tip. Okay, so here the appendix that has this is the normal thickness of a bowel wall, including the appendix, 2 to 3 millimeter, and here is up to 5 millimeters. So we diagnose this acute tip appendicitis. Now, the role of acute appendicitis in adult is generally actually limited. And the reason is the anatomy, because most of the appendix, at least the beginning, is retroperitoneal behind the cecum. Some of them then become intraperitoneal and become visible, but majority of this appendix remain retroperitoneal. And in front of here, we have the cecum that is in most patients is filled with bowel gas. So again, the bowel gas will block the sound wave. And the idea actually is try to compress the cecum so we can see behind it and look at the appendix. This is kind of hard to do in adults, especially when they're large, or especially when they have pain and tender. They're not going to let the operator to compress. So that's the limitation for that. So in generally, in adult, for acute appendicitis, we prefer CT. So ultrasound is mostly used in the pediatric age and in pregnant patients. So in pregnant patients, nowadays, we still try ultrasound sometimes, but I think if we cannot find the appendix, or sometimes we just prefer to send the patient to MR. Pediatric age, again, we try ultrasound. Nowadays, a lot of machines, CT machines, smaller machines have a lot of way to limit the radiation. So a lot of time, these patients, especially when they get a little bit older, still sent to CT. Remember that pain originating in the pelvis is not felt down in the pelvis. It's radiated to the lower abdomen. So the patient may come with right lower quadrant, left lower quadrant pain. And actually the source is in the pelvis. So it's something to remember in female patients. Okay. So here's a young patient that come with right lower quadrant pain. And actually one of the differential was acute appendicitis. But then we found out that the LMP, last menstrual period, was 6 weeks prior. And then they did a pregnancy test and they got a positive beta HCG. So this patient is pregnant. Okay? So then the patient was sent for a pelvic ultrasound. This is a transvaginal exam where the probe is put in the vagina. And here we see the uterine cervix, and this is the body of the uterus, and this the fundus. This is the endometrium, and the endometrium is collapsed. If this patient is pregnant by 6 weeks, we should see a gestational sac. So this is an empty uterus. An empty uterus plus a positive beta HCG means that the patient is at risk for having an ectopic pregnancy. Okay. On top of that, there's a little bit of fluid. Fluid is normally seen as a physiologic finding in female patients. Also did a transabdominal, and here again you can see some fluid here in the cul-de-sac, which is still okay. You see some fluid around the bowel. not commonly seen, but sometimes seen in some patients. But then we look at the upper abdomen and we see fluid in the hepatorenal space. So this is too much for this physiologic fluid. So the suspicion for ectopic rupture pregnancy is increasing. And then they also have this finding in the pelvis in the transvaginal exam, finding the ovaries. Here we have a influted corpus luteum cyst from a prior ovulation, but there's all this mass around the ovary, which is a clotted blood because some free blood there. And also on the other side, here's the other ovary with some follicles, also with some heterogeneous fluid around it. So by putting them all together, this is a ruptured ectopic pregnancy. Patient also with left lower quadrant pain, 35 years old, coming with fever, chills, having elevated white counts, so it's obviously septic. Differential diagnosis, patient with left lower quadrant pain and fever, acute diverticulitis often, but this is kind of a young patient. So was sent for pelvic ultrasound. This is what they found. We see a tubular, tortuous tubular structure with some debris. This is in the region of the adnexa. So this is a biosulfings or a TOA, tubal ovarian abscess. So I'm going to close with the take-home points. Ultrasound plays an important role in patients with acute abdominal pain. So next time you work in the emergency room, or OK day, patient with acute abdominal pain, think of ultrasound. Often it makes the diagnosis, or at least determine what you should do order or to do next. Ultrasound is fast. Of course, now they have a competition from CT, because now with the spiral CT, you can do patient in a few seconds. It's portable, which is kind of important. Patient that cannot be moved, patient at 2-6, or so the ultrasound machine can come to the bedside of the patient. It's widely available. Okay, and the price of ultrasound machine, a full-fledged ultrasound machine, is generally about 1/10 of a CT or an MRI. And also it does not have any biologic effect. There's no radiation effect like we have on CT or other radiographic exams. It's important that as a clinician, you provide good information, because it helps the radiologist to make the correct diagnosis. And finally, to remember that ultrasound is highly operator dependent. So we need operators that know how to do the exam, that are trained well, and also how people that are trained to interpret the exams. So with that, I'm going to close the lecture. Thank you very much for listening. Thank you for your attention, and I'm open to any questions.
Terima kasih Prof. Antoni Setiawan yang telah memberikan paparan cukup menarik dan penting tentang ultrasound, khususnya tentang akut abdomen. Kemudian kita masuki sesi tanya jawab. Saya persilakan ke audiens, kalau yang mau nanya mungkin bisa raise hand, ya, atau mungkin bisa chat ya di chat box ya.
Ya, silakan.
Ya.
So the question is, ini kata-katanya lengkap. The how to rule out mesenteric. What was the question?
Yes. Okay. This good. This from
Okay, here is it.
Yes, Prof.
Okay, yeah. So mesenteric adenitis, itu the mesenteric lymph nodes itu biasanya di the mid or lower abdomen. Jadi ini the area that ultrasound generally tidak bisa menembus itu bowel gas. Jadi kalau the patient with mesenteric adenitis, then we go straight to CT. Mesenteric ischemia, the same thing. Itu jadi ada edematous bowel loops. Itu juga itu the area of CT. Dan juga biasanya kita melakukan CTA, jadi CT angiogram. untuk melihat jadi SMA, the mesenteric arteries and the celiac axis. Jadi memangnya differential diagnosis dari appendicitis, terutama untuk pediatric age is lymphadenitis. Jadi that's a diagnosis for CT.
Silakan mungkin lainnya kalau mau nanya. Prof, yang sering sambil nunggu pertanyaan berikutnya, untuk keperluan fasting, Prof. Kadang untuk gallbladder, kadang
Ya, jadi untuk
fasting gimana, Prof?
Ya,
berapa jam?
Ya, jadi untuk rutinnya kalau kita untuk patient yang outpatient ya, jadi patient di klinik itu kita haruskan fasting. Jadi dari dinner yang, jadi kita bilang fasting past midnight. Jadi makanan terakhir itu waktu dinner, nanti bisa pagi-paginya kita schedule untuk ultrasound. Jadi mereka biasanya fasting 6 to 8 hours. Okay. Ada artikel di, I think it was the mid-80s, di mana orang itu mau melihat apa efeknya fasting itu untuk examination. Because sering kita bilang, wah kita tidak bisa lihat pankreas karena pasiennya terlalu banyak gas. Okay. Dan mereka lakukan itu, mereka lakukan pemeriksaan abdomen sebelum dan sesudah makan. Dan ternyata it doesn't matter whether you eat or not eat. If the pancreas is visible, then you're going to see it. And if pancreas is not visible, you're not going to see it. And the factor is the size of the left lobe. Jadi kalau left lobe-nya kecil, hypoplastic, dan semua bowel gas itu naik di epigastrium, dan walaupun pasiennya fasting, dengan fasting kita bisa collapse stomach, tapi colon tidak bisa di-collapse. Kalau left lobe-nya besar, jadi a little bit larger, then is to push the bowel gas inferiorly, and we can use the liver as a window to see the pancreas behind it. So the only reason for fasting is the gallbladder. Okay, a contracted gallbladder can hide small stones if it's tortuous. So kalau kita ada patient dari emergency room, terus dia baru makan, kita gallbladdernya contracted, dan kita bilang, we don't see any large stone, however, small stone can be missed, and the patient needs to repeat study with fasting.
Okay, thanks. Mungkin audience kalau mau tanya, silakan. Untuk stone, Prof, kadang tanpa shadow membedakan calcification atau stone itu, Prof, di renal stone itu atau suatu kalsifikasi di ginjal, Prof. Mungkin
Kalsifikasi di mana?
Di ginjal, di
Ya.
kalsial kadang ada hiperechoic. Itu untuk membedakan suatu stone atau mungkin suatu kalsifikasi.
Ya, jadi kalau ada calcification, kita mesti melihat location-nya. Kalau di renal pelvis, jadi itu di daerah dari renal sinus itu yang kita bilang sebagai sinus fat, itu tempatnya renal pelvis dan achilles. Jadi kalau ada calcification di sana, itu kemungkinan besar itu a stone. Kalau calcification-nya itu peripheral sekali, dekat kapsul, itu calcification di parenchyma. Jadi di dalam renal cortex, jadi patient barangkali ada prior trauma, ada prior infeksi, prior infarct that calcified. Okay. So location is important, dan yang saya tidak sebut itu tadi karena waktu itu kita bisa membedakan dari renal tissue, renal parenchyma, yang mana medula dan mana cortex. Jadi medula itu juga disebut sebagai renal pyramids. Jadi kalau calcification-nya itu di ujungnya piramid, itu kemungkinan bisa stone. Tapi kalau di misalnya more peripheral than that, then it's a parenchymal calcification. Yang susah sebetulnya kalau ada calcification dari renal arteries. Kita kadang-kadang juga di CT kita not so sure ini calcification-nya di renal artery atau di atau stone. kadang-kadang kita bilang kita nggak bisa tahu. In general, kalau ada intrarenal artery calcification, itu the main renal artery calcified juga. Jadi kalau ada patient with diabetes, for instance, yang ada calcification, Monkeyberg calcification, itu di mana arteri kecil-kecil juga calcified, itu bisa ada intrarenal calcification dan kita tidak bisa bedakan dengan stone. Tapi kalau generally, kalau the main renal artery is not calcified, then you're not going to see intrarenal calcifications.
Silakan audiens kalau ada yang mau raise hand, mau tanya. Sambil nunggu pertanyaan lain.
Ya, ada pertanyaan mengenai the role of intervention radiology in acute abdominal cases. Wah, ini agak susah ya, sebab saya nggak interventional radiologist. Ini di university saya ini kita dibagikan in narrow section. Jadi saya only take care of abdomen, pelvis, dan vascular ultrasound dan CT. Dan ada section lain yang melakukan interventional. However, sampai kira-kira 2 tahun yang lalu kita masih melakukan banyak intervention, terutama untuk abscess drainage. Jadi kalau ada patient dengan abscess, kita lihat dengan CT, kita gunakan CT guided catheter drainage. So that's as far as I can tell you about the role of intervention radiology. Intervention radiologist sekarang juga melakukan CTA. Jadi kalau angiography, catheter angiography itu sekarang banyak di replace menggunakan CT angiogram. Jadi kita inject contrast, then the arterial phase. Kita reconstruct arteries, jadi kita seperti melakukan angiogram tapi tidak memakai kateter. Jadi itu tadi pertanyaan tadi mengenai patient dengan mesenteric ischemia, itu generally di CTA dilakukan untuk lihat apa ada blockage dari superior mesenteric artery atau the IMA. And the same time kita juga bisa lihat komplikasi dari mesenteric ischemia, bowel ischemia, bowel edema, pneumatosis, and so forth.
Silakan audiens kalau masih ada yang tanya. Untuk imaging appendikogram, Prof. Kalau di USA apa masih digunakan?
Kenapa? I'm sorry, say it again.
Appendikogram dengan kontras imaging pada appendix. Apa masih appendikogram?
Menggunakan kontras apa?
Barium enema.
Barium enema. Rasanya kita nggak ngelakuin lagi. I think CT is so much faster and so much better. Tapi kalau I think barium enema itu kan harus fill the cecum, and then mesti kalau nggak reflux itu kita nggak tahu itu karena blockage atau apa enggak. And CT is just so much better. Kalau you find an appendix that's 6 millimeter, then you say there's no appendicitis next case. And I think jauh lebih cepat pada barium enema. And I think the patient comfort juga loh. The barium enema is not a pleasant study.
Silakan kalau mau ada yang tanya.
Mungkin dari chatting, Prof. Anthony, you can read the chatting the 2 question there.
Okay, sure.
Ya.
Ya, silakan.
Mungkin dibacakan Dr. Epri chatting.
Please.
Ya, ini ada. Saya bisa baca ini. Radiologic different diagnosis, obstructive jaundice without bile duct dilatation and ultrasound. Kalau obstruction intrahepatic, of course kita tidak bisa diagnosis. I think intrahepatic obstruction is diagnosed by biopsy. Kalau obstruction is extrahepatic, then the bile duct has to dilate. Ada satu condition where you can have dilated bile ducts, but this is not obstructive jaundice, where the common duct is not dilated, and that's a patient we call sclerosing cholangitis. Jadi karena repeated cholangitis itu ductnya jadi skleros, jadi nggak bisa distend. Tapi itu keadaannya itu juga nggak obstructive, so I cannot think of a condition with obstructive jaundice without bile duct dilatation and ultrasound. Patient yang ada Klatskin tumor yang saya sebut tadi, kalau obstructionnya is at the origin of the common duct is going to be normal. Tapi intrahepatic kita mesti bisa lihat dilated bile ducts. I cannot think of any other condition that does that. Okay, so I'm going to go to the next question. Right upper quadrant pain. Can we only do USG after more than 8 hours? Because one thing does is still become the first examination still condition, or is the examination that could do because time was too far from the first onset? Kurang jelas ini pertanyaan. If a patient come with right upper quadrant pain, and we can only do ultrasound after more than 8 hours, because one thing and another, does ultrasound still become the first examination and still be used in this kind of condition? Or are there other examination that we can do because the time was too far from the first onset? Sebetulnya kalau tambah lama, jadi itu yang susah itu sebetulnya kalau kita, seperti contoh yang saya kasih tadi, kalau we scan this patient too early, then the patient do not have any tenderness and do not have any gallbladder edema, may not have any fever. The white count in the example was still elevated. As you know, that sometimes kalau kita stress, itu ada leukomoid reaction. Tapi nggak sampai 15 or 1,000. So 11 was considered like a leukomoid reaction. But if you wait to 6 to 8 hours, then acute cholecystitis happen. And selalu kita bisa lihat tenderness, kita bisa lihat edema of the gallbladder yang ill-defined tadi itu. Jadi akhirnya sebetulnya tambah lama kita tunggu, gejalanya mesti tambah jelas. Ada tes lain yang juga bisa dilakukan, nuclear medicine test, namanya HIDA scan. Itu dalam kasus-kasus yang agak questionable, kita kadang-kadang kita send ke nuclear medicine. Jadi dengan HIDA itu di-excrete through the liver, and it's going to excrete it like bile, and it never enter the gallbladder. So the diagnosis on the HIDA scan is obstructive cystic duct. So I hope I answered that question. Next question is there any place for technology development of ultrasound combined with artificial intelligence detection or classification of disease? Ya, ini sekarang AI itu lagi hot. I think ultrasound is an area where artificial intelligence is probably not going to be affecting for a while. And the main reason is that ultrasound is very operator dependent. Jadi examination is not standard. Okay? It depends on how and where the technologies is do the study. AI is going to work on imaging that have a standardized kind of study. You know, kalau seperti mammogram itu kita is always taken the same projection, and the AI we can determine whether they can find a nodule or not, and even determine whether it's benign or malignant. I think AI is also used to find pulmonary nodules in CT, and that's the same thing. That's a fixed kind of imaging. Kita dissection the lungs all the same way, but ultrasound is too variable for AI to affect that. And then there's another question. I had difficulty detecting ectopic pregnancy unruptured case. Would you give me some tips for me? Sebetulnya kalau unruptured itu shouldn't be that hard. Okay, so the first thing you do is to look at know the patient is pregnant, but the beta HCG, and then look in the uterus. Okay, the uterus empty. Then you say this patient is pregnant, but not in the uterus, and therefore has the big ectopic. Okay. The pitfall in ectopic pregnancy is, saya nggak ngelakukan OB ini, jadi yang saya ngomong sekarang ini is things that I learned during my residency 40 years ago. I think it's called pseudo-gestational sac. So kalau ectopic pregnancy is interrupted, withdrawal of the pregnancy causes bleeding in the uterus, and so that fluid may look like an early gestational sac. So kita mesti hati-hati sama itu. Okay. And tapi kalau uterus is empty, then you start looking in the annexal area, and if it's not ruptured, then you're going to find a pregnancy. So look in the ovaries, next to it, where the tubes are. Look for a gestational sac, and if it's late enough, you'll find a little fetus. Yang susah sebetulnya kalau ruptured, because then you have like this heterogeneous mass, but before you call it a mass, things like that may be actually a blood clot or clotted blood.
Silakan, Auden, kalau masih ada.
So I hope I answer all these questions. Kalau ada still question upon my answer, silakan.
Ya. Sambil nunggu pertanyaan, Prof. Oh, ini ada chat box, Prof. Any question? At chat box. Silakan. Ya, kalau Auden yang ada mau bertanya.
Lagi ya. Kalau nggak kelihatan saya.
Oh, enggak sih. Sambil nunggu pertanyaan, mungkin Prof, untuk ureteral stone, Prof, barangkali ada tips ultrasound untuk ureter stone.
Ya, ureter stone itu seperti yang saya tunjukkan tadi. Kalau once the stone is outside the kidney, itu ureter itu kan jalannya di ureteroperitoneum, ada bowel gas di depannya, jadi kita nggak bisa lihat. So the ureter is not visible in general unless it's very dilated. Tapi generalnya kita terus melihat di bladdernya. Jadi kalau stone-nya itu stuck di ureter-vesical junction, itu kita bisa cari di sana. Jadi biasanya kalau di tengah-tengah di ureter itu kita nggak bisa lihat ya dengan ultrasound. So, but in general, kalau patient come dengan flank pain, itu tahu, limitation of ultrasound at least di tempat saya itu, patient go straight to CT.
Oke, saya kira sudah tidak ada pertanyaan lagi, mungkin dari Auden.
Oke.
Ya. Kalau tidak ada, saya kira bisa saya sedikit simpulkan. Jadi memang untuk akut abdomen itu penting dengan pemeriksaan ultrasound ya. Jadi dengan ultrasound perlu perhatikan lokasi nyeri pain ya, nyeri lokasi dari abdomen. Dengan nyeri abdomen kita bisa evaluasi kelainan-kelainan apa yang kemungkinan bisa dideteksi dari ultrasound. Kalau tidak ada lagi, mungkin saya akhiri sesi tanya jawab. Untuk acara saya kembalikan ke Dr. D. Terima kasih, Prof.
Ya, kembali. Yes, sama-sama.
Dr. D. Ya.
Thank you so much to Professor Anthony for the very insightful lecture and also for the updated knowledge for all of us. Terima kasih untuk Dr. Eprianto atas moderasinya juga. Saya yakin semua yang kita dapatkan pagi ini akan berguna bagi kita apapun levelnya ya, baik kita mulai dari yang mahasiswa sampai yang dokter umum maupun hingga yang radiologis, bahkan saya yang sebagai seorang dokter spesialis yang non radiologi. Acara pada pagi hari ini akan dilanjutkan dengan penyerahan sertifikat secara simbolis kepada narasumber oleh dekan. Kepada tim IT, mohon bantuannya untuk ditampilkan.
Okay, Professor Tony is my colleague, my friend. Thank you very much for your lecture. It's very interesting, and I think this make our student open-minded and know about how far the medical knowledge in your country. Yeah, and then it's good for the student to know what about USD, the role of the USD, abdominal diseases. That's our appreciation for your term, this one. I want to give you this our certificate appreciation from our medical school, Widya Mandala, Katolik University Surabaya. And thank you. And I hope for the next lecture, it will come in essential learning series 2 on the topic of the role of CT scan in abdominal. Okay, Professor Anthony, thank you for your lecture.
Ya, terima kasih kembali. Jadi saya terima kasih untuk Profesor Talili. Saya beri kesempatan ini, dan jika bisa ikut merayakan ulang tahun yang ke-11 dari Fakultas Kedokteran Widya Mandala. Terima kasih.
Terima kasih. Nanti ketemu lagi tanggal 23 ya.
Iya, betul.
Anthony. Ya, okay, good. Ya, we have a good collaboration, and when you back to Surabaya, please our campus that is in the background is my campus.
Yeah, sure.
Mandala
Hopefully,
School,
seperti saya bilang, hopefully in end of next year. Itu rencananya.
Okay, thank you. Yes. You can see how about our campus. Yes.
Okay.
Dr. Dev?
Ya, baik, Prof.
Ya.
Once again, thank you to Professor Anthony and Professor Paul. Kami berharap agar informasi yang telah semua kita dapatkan dan juga kita sampaikan ya dapat berguna bagi segenap rekan-rekan yang menghadiri pada pagi hari ini beserta teman-teman mahasiswa dan mahasiswi sekalian. Sebelum kita akhiri, marilah kita tutup dengan doa. Doa akan dipimpin kembali oleh Dr. Marilyn. Silakan, Dr. Marilyn.
Ya, jangan lupa ada foto ya.
Oh ya,
Jangan
nanti
lupa
setelah doa jangan langsung meninggalkan, akan ada foto bersama. Minta mahasiswa dan rekan-rekan sejawat semua on camera.
Baik, mohon izin saya tutup acara pada pagi hari ini dengan doa. Doa akan saya pimpin secara Katolik, bagi yang beragama lain dapat menyesuaikan. Dalam nama Bapa dan Putra dan Roh Kudus, amin. Allah Bapa yang penuh kasih setia, kami bersyukur kepadamu atas bimbingan dan kasih-Mu yang kami alami selama acara ini berlangsung. Bapa, kami juga mohon penyertaan-Mu untuk seluruh rangkaian acara GSPS ke-11 depannya. Kiranya Engkau selalu menyertai agar semuanya boleh berjalan dengan lancar sesuai kehendak-Mu. Semoga apa yang telah kami laksanakan pada pagi hari ini dapat berguna bagi hidup kami dan berkenan di hadapan-Mu. Dikau kami puji, kini dan sepanjang masa. Amin. Dalam nama Bapa dan Putra dan Roh Kudus. Terima kasih, Dr. Dev.
Ya, untuk seluruh hadirin, mohon menyalakan kamera. On camera semua, kita akan melakukan virtual photoshoot. Untuk mahasiswa yang belum menyalakan kamera, mungkin mohon dikoordinir komting tiap angkatan ya, untuk kabarin teman-temannya semua. Menyalakan kameranya.
Cukup banyak yang ikut, Prof. Antoni. 257 partisipan. Wah, luar biasa. Very interesting. Ini mahasiswa-mahasiswa kami, calon-calon dokter kelak ini.
Mahasiswanya aja semua berapa?
Total kalau tidak salah ya sekitar 700 kami. 700.
Wow.
Mahasiswa
Dari
kedokteran.
semua tingkat itu 300.
Ya betul, sampai dengan koasisten. Ya.
Si dokter, permisi Prof untuk
Ya, silakan. Si komando aja.
ya. 1, 2, 3.
Ya. Next. Jangan lama-lama, Pre. Anugerah.
1, 2, 3.
Banyak ini.
Untuk halaman
Kalau
ketiga,
bisa
1,
senyum
2,
ya.
3.
Kalau di foto senyum ya. Mahasiswa ini harus senyum semua itu.
Halaman keempat, 1, 2, 3. Halaman kelima, 1, 2, 3.
Sorry, so many.
Halaman keenam, 1, 2, 3. Halaman ketujuh, 1, 2, 3. Halaman ke-8, 1, 2, 3. 9, 1, 2, 3. Yang terakhir, 1, 2, 3. Sudah, Prof? Sudah, Dokter?
Oke. Sekali lagi terima kasih Dr. Antoni, Prof. Antoni, Dr. Dev, Dr. Epri, Dr. Puji, para wakil dekan, Dr. Andi, Dr. Gledy, Dr. Stephen, para dosen sekalian, dan para mahasiswa. Salam sehat, salam sejahtera. Kita ketemu lagi nanti dalam Essential Learning untuk Profesor Antoni pada tanggal 23 Maret ya. Tapi minggu depan ada lagi dari Jerman, yaitu Profesor Khalid Asad, seorang ahli dalam skin cancer. Dia akan memberikan juga lecture pada kami. Terima kasih, sampai jumpa.
Saya mewakili panitia, mohon maaf jika ada ucapan kami yang kurang berkenan selama berlangsungnya acara pada pagi hari ini. Mengingatkan juga untuk mengisi absensi melalui link. Mungkin boleh dibantu share ya untuk absensinya. Oke, terima kasih. Akhir kata, saya Dev selaku pembawa acara, saya pamit undur diri. Sampai jumpa pada Essential Learning berikutnya, seri kedua. Selamat pagi dan salam Widya Mandala.
Selamat pagi.
Ya. Selamat pagi semuanya.
Bye.
Ya, selamat pagi.
Ya. Tanggal 9 jangan lupa Profesor Asad, Khalid Asad dari Jerman. Ya, beliau keturunan Palestina tapi warga negara Jerman. Ya, menarik sekali nanti. Selamat pagi, sampai jumpa. Kita live ya.
Oke, bye-bye.
Salam sehat, bye-bye.